So, to everyone who's listening, this is Dr. Daniela Cruziat. She is a cardiologist who specializes in women's health as it pertains to cardiology, but also has this very unique perspective and expertise in cardio-obstetrics, which we're going to talk about. She went to undergrad in Gainesville, went to NYU Medical School, then Brigham and Women's Hospital for internal medicine, and Mass General for cardiology fellowship. And now she is at the University of South Florida in Tampa General doing just some amazing work. So Daniela, thank you so much for being a part of this production today.
Thank you. I'm really excited. Thank you for having me. I think I agreed to be on this before I knew it was called You're So Vain. It's always so hard to talk about myself, but honestly, I'm just delighted to be able to share my story with anybody who's listening.
So the good thing about the vein part is that it's actually a vein like the blood vessel. So, it really just pertains to things that have to do with your health and have to do with your circulation and just being a cool person.
I love that. Sounds better than You Are So Artery. So we'll take
Correct.
it.
Which would just be a silly name, wouldn't it?
Yes.
Okay, so Daniela, let's talk a little bit about what or who or both influenced you to do medicine in the first place.
That's a great question and something that I think about all the time. And I really, when I spend time with my trainees and I look back, sometimes it's a little hard to figure out that one aha moment. Like, when did I decide I wanted to be a doctor, a cardiologist? My beginnings are really humble. I was born and raised in Venezuela, and there's only one physician that I knew, and that was my grandfather, my mom's dad. And to this day, when I asked my mom, what did he do? What kind of doctor was he? She was like, I don't know. He was just the community doctor. Everybody went to him and he would care for everybody in our community. And that's the kind of role that he played. And to this day, I think he was probably a general internist. Not really sure what kind of residency he did, but that really didn't matter. And I think that was instilled in me early. And I said, what a cool thing to be able to give back to people, for people to have the confidence to trust you, to come to you with their ailments when they're not well. And I think that's really what forms sort of the beginnings of my interest in saying, and there's many ways you can give back. It doesn't have to be in medicine, right? I was like a little nerdy, if I may say so. I was always very science focused. I loved math. I was someone who was undecided when I went to college at University of Florida. I actually applied as exploratory. It used to be a major that you could pick when you literally had no idea what you wanted to do. And I took marketing classes. I took anatomy and physiology, which, as you guess, I loved. But I was a little bit all over the place, but I always kept that in the back of my mind. I felt very privileged to have the opportunity to come to this country, to be the first to attend college. And I wanted to figure out a way of, how do I give back to my community? And I wanted to find a way that I loved, but maybe that I was also good at, right? Was, you could guess, when I applied to medical school and even residency, I always envisioned myself giving back to my community. And for me, that always felt like giving back to my local sort of Hispanic community. I spoke Spanish. My parents had always instilled that in us. And I said, how wonderful to go to a physician who can speak your own language. So I envisioned myself, and it's funny because right now I'm standing in a different place, but I felt like I'd probably work at a community health center. I want to give back to my community. And I think I would be happy if I did that for the remainder of my life. What I really tell trainees is you got to keep your eyes and ears open. As I went through my training, I was like, oh, the heart, that's pretty cool. And I've never been really good at memorizing, but anatomy and physiology just made sense to me. And we're talking about veins and arteries and hearts and a little bit of physics. And I really became captivated by that. But one piece of information that I always give to my students and my mentees is, go back in time, read all of your personal statements, figure out where you came from. What did you write when you applied to college? Where did you think you were going? How did that change when you applied to medical school and residency? And I went back, and it always said, give back to my community, be a voice for the people who can't be a voice for themselves. And when I finally reached geology training, I think that was one of my aha moments, because for many years, I didn't realize that women were actually a quote unquote minority. They're not a minority, right? We make up 50% of the population. But I said, wait a minute. I feel like women don't really have a voice. I feel like women are underrepresented in the field of cardiology. I felt like women were underrepresented in research. And I also felt like women weren't really being listened to. And that was a little bit of my aha moment that really brought me to where I am today, which is like, how did I end up wanting to be like a community, health provider? And how did I end up directing and running a women's heart and cardio-obstetrical program at the University of South Florida? When people say, did you end up where you thought you were going to be? I'm like, no way. I did not even know that, as we'll talk about, women's cardiology or cardio-obstetrics is a subset that I now devote pretty much 100% of my clinical research and quality and public health initiatives on. But when I sit back and I think about it, I do think that this is probably where I need to be
Oh
and
my
maybe where I
goodness.
wanted to be.
I love that idea of going back over your personal statements because I do think that there is a reason that we are guided to do the things that we end up doing. It doesn't happen in a vacuum. I think about the fact that I do vascular surgery here, which is so completely different than what I thought I was going to do. I went into medical school. I went to Mount Sinai. I know you were at NYU. I was at Sinai. And I was going to do adolescent healthcare. And I was going to go out into the community and I was going to help these kids who were struggling. And it's funny because now I feel like I still am helping kids who are struggling, but they're kids who are like going into residency and trying to figure out how to take on this very hard task of becoming a vascular surgeon and how do you navigate the struggles of that challenge. So it is interesting how you keep a hold of those desires even as you're progressing through a field that seems totally different than what you were going to do before. But the other thing I was going to bring up or ask you about was this idea of cardio obstetrics. Now, before I had, and I used to work in a women's hospital, you and I have discussed how I didn't even realize that was a term. So, explain to me a little bit about what it means and why there is an interest, particularly in the heart when it comes to pregnant women. It obviously it seems like it would make sense, but it seems like there are certain diseases that in pregnancy that can put women at risk for heart disease in the future and probably as a corollary vascular disease as you and I have talked about.
I think a lot of people maybe haven't heard the term cardio obstetrics either. And we always like when we get around a table with a bunch of cardio obstetrics experts, we can also talk about what does that really mean? And how do you become an expert? I think we always think back to like, when was the time each of us heard that? Did we see it on social media? Was there somebody who just referred to us? But really, the world of cardio obstetrics, I think, has existed for some time. I think in its earliest sort of renditions, it really involved kids being born with congenital heart disease. And as soon as sort of surgeries and corrective treatments became available, some of these children were living to adulthood and thinking about starting their own families. And of course, when we think adult congenital and we think pregnancy, talk about people being uncomfortable, right? It's sort of an area where you're like, they probably just shouldn't do that. So that's
Yeah.
where that's where when I hear that, we probably shouldn't do that, but in an area of no evidence, is really what kind of gets me going. So once I was in cardiology fellowship, you mentioned I went to MGH. I was lucky enough that they had a women's heart program there. I was like, oh my God, how novel, a whole program for 50% of the population. But then I quickly realized why it was so novel. And it was because women needed to be paid attention to. Women had certain sex specific risk factors. Women have a reproductive lifespan that can impact their cardiovascular health. And then on top of it, they're like, oh, do you want to rotate with our pregnancy heart team? That's what they called it. I said,
Mm.
wow, that's pretty cool. What does that mean? You just see pregnant women, but like, I don't want to deliver babies. I say from the diaphragm up. That's what that would be my joke as the person who passed out when they saw their first live birth in medical school. So I was like, OBGYN, not for me. And they're like, no, here's the ticket. And as soon as I was spending time with this cardio B service doing exactly that, we were counseling women before they're heading into what we know is probably, it's funny, I'm a cardiologist. We send people for stress tests like there's no tomorrow. But this is nature's hardest stress test for women. It's pregnancy itself. Why put them on a treadmill? How about you have them make a baby for 10 months? So then we were counseling women what that kind of marathon and what pregnancy could do in the context of their heart disease. We were creating pregnancy plans to come up with what do we do if you do or we get on this journey and become pregnant. But then, interestingly, the whole world of like what happens to a woman after a complicated pregnancy and the importance of having to follow them lifelong. That really is what people talk about, quote unquote, cardio-obstetrics. It doesn't just mean I delivered your baby. It really means like all the way from earlier is better, preconception, so adolescent, talking to people about their potential risks. We know that at least 80% of women will be pregnant one time. So it really does become important. And along with this movement of cardio obstetrics, if you turn on the 6 o'clock news on a given day, you'll find these graphs about maternal mortality. And the US really doesn't look good, even compared to underdeveloped countries. And we just see a steep rise in maternal mortality. And when people ask the question, why are pregnant women or postpartum women dying? One of the leading causes is cardiovascular disease. So I was like, that's it. I'm
Right.
going to be a voice for women. I'm going to try to do advocacy for them. But we have such a long way to go. Some days I wake up and I'm like, wow, it's 2026. We still don't study them. We don't include them. We use treatments and therapies that we know have worked in other populations. So I think we still have a long way to go, but we got to start somewhere, right? It's
Absolutely.
probably going to take decades, but we got to start somewhere.
So talk to me about what you think is happening with the maternal mortality rate in the US. Is there an understanding of why that's happening? Is it a social determinants of health-based issue? Is it an education issue? Is it just all the preservatives we have in our food? What is happening that is making that happen? Like that
Yeah.
statistic be so high and
So
dangerous?
high. Yeah. It's highly debated. And at the end of the day, like most things, it's probably a combination of a lot of those factors. But there's a few things that we know are true. The women in our country are becoming pregnant now look very different than the women in our country who became pregnant a couple of decades ago.
Okay.
What that means is women are now getting pregnant at an older age. So we're seeing an uptick in sort of the median age of first time pregnancy. And that's something that's throughout the US, of course, with geographic variation. We're seeing that women who are getting pregnant now have more acquired risk factors. So listen, they may not have a cabbage or a stent or have known coronary artery disease, but they are a high likelihood of being overweight or obese, having hypertension, having prediabetes or diabetes. And on top of that, we definitely know your question about social determinants of health. We just can't have a conversation about maternal mortality without them, right? We see that women who identify as Black are 4 times the risk of dying as a woman who is white, either during pregnancy itself or in the year postpartum. So a lot of questions come up about, is it really just race? Probably not. Is it something about genetics or is it something more about where these women live? How are they accessing the healthcare system? What's the quality of the healthcare system that's close to them? And also, how do the other things that determine their health, such as food security and housing security and access to healthcare, how did those things play a role in terms of, did they get preconception counseling? Did they actually get what we consider good prenatal care during that pregnancy? And honestly, do they live near a place where they can access a cardio obstetrician? I spend nights thinking this is great that we have this here at the University of South Florida and Tampa General, but when you look across, there is such a shortage of that degree of specialty, but there's such a mass need for it, right? And then you ask the OBs, and they're like, oh, the cesarean deliveries are too high. We need to cut those down. Maybe that's why we're having worse outcomes. So at the end of the day, I think it's a combination, but at least from the cardiac perspective, I can tell you the moms are less cardiovascularly healthy at the time of pregnancy. And if pregnancy is indeed a stress test, we're seeing women fail that stress test. And that's kind of the language that I use.
Yeah.
And it sounds terrible. No one likes to fail anything, a test, any kind of test, school or pregnancy itself. But all of those adverse outcomes, having preeclampsia, having a preterm birth, getting, oh, I just had gestational diabetes, but it's probably going to be okay. We know that all of these are now sort of red flags that really increase the long term risk of cardiovascular health. When people think cardiocentrics, and I go, you just care for them during their pregnancy, I take a step back. I'm a women's cardiologist, right? These women, a lot of them deserve to be followed and will remain at risk for the entirety of their sort of reproductive lifespan and beyond that. So it really is not just about pregnancy.
It is. It is healthcare along a lifespan, really, for or cardiac risk management, I would say, or vascular risk management along a lifespan. One of the things that I remember you and I spoke about, and there's so many different ways I think we could take this conversation, given what you just said. We had this conversation about this theory about kids who maybe were infants who were born prematurely and what their risks of getting hypertension, diabetes, and obesity at an early age looks like. Because what that makes me think about is that if the mother is not in the best of health, let's say they have hypertension or they're at risk for preeclampsia or they have gestational diabetes, and they end up giving birth to an infant who is premature because of some of those risk factors, then that infant themselves has their own set of risk factors for cardiovascular disease in the future. Am I right about that? Or is that,
Yes.
and what's the prevailing theory on that, if there is one?
Yeah. So you may have heard of something called the Barker hypothesis. It's sort of the hypothesis that what happens in that intrauterine environment, and here I am as a cardiologist talking about placentas and uteruses, which is why cardio-obstetrics is just so cool. So I do have my limitations on placental biology, but it's really that paradigm and that hypothesis that you're right. The environment that the fetus is in, the health of the vessels that are feeding the fetus. Because again, a lot of it goes back to placental biology. That's the reason why we think women are getting preeclampsia. That may be one of the reasons why babies are at increased risk for intrauterine growth restriction. And I am just a cardiologist. And sometimes I'm like, oh, if I would have been a pediatrician, or if I could, but this is really where we have to come together with our counterparts, because you're absolutely right. If I have a preterm baby that's growth restricted, that actually carries risk for the offspring. We know that 100%. And we know that intrauterine environment is important, but we're not even doing a good job of flagging the women having adverse pregnancy outcomes, let alone then flagging the children of those women so that their pediatricians and their caregivers can say, I can't remember if anybody ever said, asked me questions about my mother's pregnancy with me, right? It's just not really a part of what we do. And kudos to anyone listening to this who does that. Hey, was your mom, were you delivered preterm? Or, but I would say that's probably a small minority. But that really highlights just one, it's more than just it's really a lifespan approach, but one that can affect our offspring too. So, oh my goodness, look how far behind we are. But I do think we have to start somewhere. And I do think that if mothers were educated on that and knew, that also opens up a whole different door of awareness and maybe advocacy on the mother's part to say, I want my baby to, I don't know, you name it, be as healthy as possible. Let me talk to the pediatrician. My baby was growth restricted, or I had these complications. Is there any screening or anything that needs to be done earlier as their child is growing up and going into adolescence? Or even just discussions. Tell
Right.
people, I'm like, I know it's not the coolest thing to talk about your health over the dinner table, but
Right.
kind of is good to know what each of us, how each of us have gotten here, each of us have, because we know that there really truly is a connection within families, but also in mother baby dyads.
Absolutely. I've had a little bit of an exposure to that sitting on being a standing member of an NIH study section that focused on comorbidities of HIV infection. And there was a cohort of studies that would come through that study section where they were looking at mother baby dyads. So this is reminiscent of that there is potentially a link between what's happening in the mother's health during pregnancy and what is happening with that child as it grows into adulthood. And obviously, I feel like mothers feel blame all the time and enough as it is that this is not to add any extra stress. Oh my goodness, I had preeclampsia and now I've doomed my child to diabetes and hypertension, etc. But to your point, I think it does beg the question that what are we doing to ask the appropriate questions? When should we start screening our children for certain types of cardiovascular diseases? I don't deal with kids a lot, but I'm not asking that kind of information from my female vascular patients. So it does, I think, open up a whole different area of investigation, of clinical care, and of advocacy that I think could be very interesting, and certainly an area that up and coming generations would be interested in joining. And in fact, one of my partners in Pittsburgh is has already started thinking about this in the way that she is asking her female patients about their history. And who knows, maybe we'll have her on this podcast in the future. I think that could be a good corollary to this. So the other part that I wanted to talk to you about just really quickly is this idea of vascular health. And this is something you and I are going to hopefully start doing and get off the ground here. But the same risk factors that put women at risk for cardiac disease will also put them at risk for peripheral vascular disease. It's the same thing. It's hypertension, it's hypercoagulability, it's smoking, it's diabetes. It's these things that can increase the risk of peripheral vascular disease. And very similar to what we see in cardiac disease, women present differently. The risk factors may be underestimated in women, I would say. What are some of the things that a general practitioner or me as a vascular surgeon or another type of nephrologist or something should be thinking about when they're seeing a woman of a certain age in their clinic in terms of their overall cardiovascular risk?
Yeah. So I love this question because it makes me think of two things. I think one, I think we by far underestimate, both consciously and unconsciously, underestimate a woman's risk of cardiovascular disease. And I think the reason for that is because even if you go back, and I love going back and looking at like AHA infographics from the 1980s and 90s, and it's basically like men and men smoking and men clutching their chest. So I think for a long time, and I also have the cover of that Time magazine from 2004 that highlights that women get heart disease too. But look at us, we're over 20 years after that, and it's still thought to be a man's disease. So I do think that when you're a nephrologist or you're in the emergency room and we know this, and you're a man and a woman and you come in the same exact way, we're not even talking about different signs or symptoms. We're always going to feel like the woman is probably less likely to have something cardiac going on. Now, people have really looked at that because for a long time, there were certain campaigns about women have different symptoms. Let's talk about coronary artery disease. So, just having a plain old heart attack. When we actually look at how men and women present, the number one symptom is still chest pain. So, like, it's still, and I hate calling it pain because people call it pressure, people call it different things, but it's still pain, pressure, a weird sensation somewhere in the center of their chest. And when we look at men and women, they actually present the same way. However, what's the difference? Women present with a whole host of other things, which I think can sometimes make it hard for practitioners to like zero in on it. A man may come in and be like, I'm having crushing chest pain for the last 30 minutes. And it's like, oh man, probably having a heart attack. A woman may be like, I'm really not feeling so well. Maybe it's what I had this morning. I kind of rushed out of the house and I chugged my coffee very quickly. I'm also a little nauseous, but I'm feeling a little lightheaded. So the studies actually do show that even though women complain about something like chest pain at the same rate as men, when they're coming in with, for example, an acute coronary syndrome or a heart attack, they have the other stuff, the fatigue, the shortness of breath, the like, I feel like I'm going to vomit. So sometimes people can get lost in that notion. Now, the symptoms for us, we feel like are pretty much equal plus. I call women's symptoms equal plus, like what men have plus a little additional. Now, what we're really the last 10 to 15 years of women's cardiovascular disease has seen that the actual pathophysiology and the etiology of heart disease is different. I'll give you another great example in comparing men and women. So men tend to have the block your arteries, build up with plaque and crud, what we call epicardial coronary disease, obstructive disease. And we see that. You go to any cath lab, men are always going to be more likely to have obstructive epicardial disease. When we look at women, most of the time they're getting cath and they're like, oh, they didn't need anything done because they didn't have anything obstructive. But we know that women are more likely to have the non-obstructive kind, yet they suffer for more symptoms, and symptoms limit life and quality. We know that they have microvascular disease. Isn't that cool? You can't even see the microvasculature, yet we're more likely to have that. And for years and years, and ask any friendly interventional cardiologist you may know, the field of interventional cardiology was all about the epicardial coronary arteries. And are you obstructed? Do you need a stent? Do you need bypass? Over the last 10 to 15 years, we've seen a change in that, where now we're recognizing different pathophysiology, different mechanisms of heart attack. Men and women have totally different mechanisms, whether it's plaque rupture or more erosion in women. Women can have dissection as spontaneous coronary artery dissection, which we see 9 out of 10 are female versus male. So when it comes to thinking about women, I think there's some things that are more sex prevalent, right? Like women are more likely to have autoimmune disease or more likely to get breast cancer. But then there's some things that are sex specific that only women can and probably do get. And those are the ones that tend to be associated with sort of the reproductive life cycle, right? Like having peripartum cardiomyopathy, that's congestive heart failure from pregnancy stress. It's fascinating to think, how different are we? And maybe, Elko, we just don't know. And maybe we just don't know. But over the last 10 years, I feel like men or women are becoming more independently thought of rather than finding a unifying thing that all patients with heart disease present this way, have these mechanisms of disease, and this is how you treat them. So we've gone a long way in saying, well, we're actually different, not just in how we experience symptoms, but like what's actually going on inside our pipes, right? Or inside our hearts. I think now where sort of the rest of the field will head into is, wow, we see that we're different. We need to start studying those things. And that's really where sort of research and innovation has got to come through for us. When you look at NIH funding, maybe about 10% of it goes to women's health. But remember, women's health also can be like migraine. It can be like polycystic ovarian syndrome. It could be breast cancer, right? Women's health. The amount going for women's cardio and vascular health research is actually pretty small. So we really have a long way to go, but that means we have our work cut out for us.
And I am so excited to do that work with you. So I really want to thank you for taking the time. I know we struggled a little bit with some of the tech parts of this, but we got through it. We're problem solvers.
We did it though. Look at us.
Look at us. We did it. It was such a pleasure to be able to hear your perspective on this. And I'm so looking forward to working with you on these projects going forward. So thank you, Daniela, and have a great
I love it. Thank you for hosting me, and thank you for bringing the vascular back into cardiovascular. I'm excited to work with you.
All right.
Thank you again.
Take care. See you later. Bye-bye.
Bye.